where everyone will be in the New Year mode. And we are also finished all those cases. So this success, I would owe to Professor Dr. Balasubramaniam. So when I approached him last year by end, sir, you should be there as the convener in selecting those cases and helping us in selecting the faculty and all. He told, sir, I will be there all the last Tuesdays for the event. So that was the words given by sir, and he made it that he was here for all the 11 events for till today. He is there from 8 o'clock to till the program is over. He will be there and he will be guiding the postgraduates with his voluminous knowledge, what he's done for the past few years. Then the next credit goes to Dr. Prasanna. So Prasanna is the person who is behind the show. He is, even though I am the president, he is the one who asked me, sir, whether this mentor is okay, whether this guru is okay, whether this session is okay. So he coordinates with all those institutes. So we have given opportunities from postgraduate from most of the institutes, because it is almost 12 postgraduates have presented, and whether it is a DNB institute or an MD institute, most of the institutes have been given the credit, and the mentors are also from all the institutes. 22 mentors we have roped in, and most of them we have the knowledge has been pulled from all those institutes. So my credits, thanks to Dr. Prasanna and Dr. Nisha also, who are the coordinators of the PG Virtual Gurukulam program. And to all those faculties, starting from various professors. So either they will be the stalwarts in IAP, or they will be a professor cadre. So all were pulled in the 22 faculties we had. And our this will be a district program. Even though it's a district program, we had almost even 110 participants on Zoom for a particular program. And this is live and on YouTube, and it is stored on YouTube also. So we have shared the YouTube link a few months before compiling all the programs, and we will do it the next month also, sir. And for this event today, we have our Professor of Pediatrics, Professor Padmasini Madam from SRMC, and a very good friend of ours and a teacher, Dr. Ganesh from Rainbow Children Hospital. So they will be, with the support of Professor Balasubramaniam, they will be dealing the two cases. And very happy that note that we are finishing this 11-month series in style on this day with the Professor Singaravelu sir also joining the show on the Zoom platform. So over to Dr. Prasanna to carry over the proceedings.
Thank you, sir. Sir, SB sir, shall we start, sir?
Sir, you are muted, sir.
Yeah, please go ahead, Prasanna. Thank you.
Thank you, sir. Sir, we have two cases today, so we'll be giving 40 minutes for each candidate, sir. Two short cases. So they will just present as a short case. We'll start with Dr. Rakshana. Can you start sharing your slide and present your case?
Am I audible, sir?
Yes, you're audible. You can start. Madam, we'll start you can stop.
Can I start, sir?
Yes. Madam, you can stop her in the middle and you can ask questions, madam. Dr. Ganesh.
Sure, sir. We will do that. And
Yes.
Rakshana, this is a short case. So we are expecting a focused history and a targeted physical examination.
Okay.
We do not want extensive details like in a long case.
Okay.
Please start.
Good evening, everyone. Myself, Dr. Rakshana, final year postgraduate from Chettinad Hospital and Research Institute. A 13-year-old female child residing in Velachery was bought by her mother. Her reliability is good. Chief complaints, child is a known case of Down syndrome and came for routine checkup. Hence, I like to start from antenatal history. Antenatal history, child is a second born of non-consanguineous marriage with obstetric code of P2, L2 and A3. First child is alive, healthy and developmentally normal child. She a girl child with a current age is 22 years. Maternal age at marriage is 29 and maternal age at second conception is 39 and paternal age at marriage is 33 and paternal age at second conception is 43. First trimester, spontaneous conception, mother confirmed pregnancy after 45 days of amenorrhea by UPT. Dating scan and NT scan not done. Folic acid supplementation taken after confirming pregnancy. No history of fever with rash, lymphadenopathy, radiation exposure, drug exposure, and excessive vomiting. Second trimester, perceived fetal movements.
Rakshana, can you pause here?
Yes, ma'am.
Where is this lady from? How come no scans were done? Isn't it a part of routine antenatal care nowadays?
Yes, ma'am. But she actually from Velachery only. She has been advised to do dating scan, but she told due to some family emergency she couldn't do the scans, ma'am.
So, how do you diagnose Down syndrome prenatally? How do you suspect it prenatally?
Okay. So ma'am, usually combined test is the most sensitivity test, ma'am. Maternal age plus double marker test, which includes beta HCG plus PA-PPA, along with the nuchal translucency in the first trimester, and in second trimester.
So you have to give complete answers. What will happen to beta HCG? What will happen to
Beta
PAPP?
HCG, yes, ma'am. Beta HCG, it will be increased, and in PAPP, they will be decreased, ma'am.
And what will be the nuchal translucency?
Nuchal translucency, it will be more than 95% for the measured crown rump length, ma'am.
Oh, that's entire. And you said this mother was 39 at the time of conception.
Yes,
So
ma'am.
what is the risk of having a baby with trisomy 21 in this
Ma'am,
maternal
actually
age?
more than 30 years, it is 1:400, ma'am. And more than 40 years, it is 1:100.
Yes. Is there any significance of fever with rash, lymphadenopathy, radiation, drug
Ma'am,
exposure?
pertaining to Down syndrome, it's not significant, ma'am, actually.
So what antenatal events are commonly seen in mothers carrying infants with Down syndrome?
In first trimester, ma'am.
Not really first trimester, in all the 3 trimesters put
And
together.
for all the 3 trimesters, mother usually they will be in third trimester, there will be growth retardation will be there, ma'am. Polyhydramnios will be present. Decreased fetal movements will be present, ma'am.
Okay, why do they have decreased fetal movements?
Hypotonia will be there, ma'am. So decreased fetal movements present, ma'am.
And polyhydramnios? Rakshana, are you there?
Yes, ma'am.
You need time to think. What is the GI anomaly associated with Down syndrome?
The more duodenal atresia, annular pancreas will be present, ma'am. And
That is the reason. That is the reason. That is the reason.
Oh, okay.
Yeah. In addition to that, because of hypotonia, the swallowing is not as good as in normal children. And there may be associated maternal diabetes.
Yeah, okay.
So we'll focus on these antenatal events in a child with Down syndrome and not on fever with rash.
Fever, okay.
Yeah, please continue.
Perceived fetal movements at 5 months of gestation. Anomaly scan done. One was said to be normal. Iron and calcium supplementation was taken regularly and 2 doses of injection TT given. No history of gestational diabetes mellitus, PAH, anemia, bleeding, PV, and thyroid disorders. Third trimester, continue to pursue fetal movements, continue to take iron and calcium supplementation, no history of GDM, PAH, anemia, and bleeding PV, and any symptoms suggestive of UTI. Growth scan was done and said to be normal. And mother was advised to get admitted at 36 weeks plus 5 days of gestation and was planned for induction of labor, but was taken for elective LSCS in view of mother's request.
I don't understand. Why would somebody want to induce labor for this 36 weeks, 5 days?
Ma'am, because of the mother's age is delayed, ma'am. So they plan for early induction at 37 weeks. They plan for early induction of labor, ma'am. At correct term, they plan to for induction of labor, ma'am.
So why don't you make it less complicated and say 37 weeks? Why do you want to say 36 weeks, 5 days?
Ma'am, just for admission purposes, they wanted to get admitted, ma'am. But plan to do an induction of labor 37 weeks only, ma'am.
Okay, and I don't think you should say elective LSCS at request of the mother.
Okay.
Obstetricians are not supposed to entertain such requests.
Okay.
It reflects rather badly, isn't it?
Okay.
Yeah, please continue.
Birth history, late preterm, AGA, elective LSES, and birth weight is 2.5. Baby cried immediately after birth. No history of NICU stay. Breastfeeding initiated within 1 hour, and urine and stool passed within 24 hours. Baby was noted to have dysmorphic faces and was told by the doctor that she could be a syndromic baby and was advised to get evaluated for the same. No history of seizures, feeding difficulty, weak cry, lethargy, jaundice in the postnatal period. And baby and mother got discharged and day of life 5.
And Dr. Rakshana,
Yes, sir.
here there is the newborn period itself. Somebody has suggested probably some syndromic baby.
Yes, sir.
Right? What are the clinical features in the newborn period to point out whether the baby has got whether the baby fits into a Down
The
syndrome?
newborn, there is
I'm
a
asking
scoring
you,
for Down syndrome, sir. Actually, it
what
is
is
known
this?
as Freit scoring, sir.
Freit scoring, or what is this Hall's criteria?
Hall's criteria.
Okay, what is that?
Hall's criteria, there are total 10, sir. Flat
Okay.
faces, eye upslanted palpebral fissure, and ear is dysplastic, neck is short with redundant skin, hypotonia, poor Morose reflex, joint hyperflexibility, simian crease, fifth finger short with clinodictally, and pelvic dysplasia, sir. Out of 10, 4, minimum 4 should be there. Then the possibility of Down is 48%, and 6 is there, now it is 89%, sir.
Okay, so this is just to till the karyotyping result comes. Only thing I was quite sure is this girl is 13 years old, right?
Yes, sir.
Is the mother able to remember each and everything in the history even after the child is 13 years?
Sir, actually,
Because 36 plus 5 weeks, past urine and stools within 24 hours. See, a small child, parents will easily remember, but for adolescent girl, 13 years old, all these minute details somebody is remembering is.
Sir, actually, she is remembering, sir. She is keeping a note on everything, sir. From birth, she is keeping a note on everything, sir. She told herself like this only, sir.
Okay, fine. Proceed.
Okay.
And another thing is,
Yes,
did this child had any developmental delay?
Yes, sir.
Okay, so probably what should have the opening statement should be with the child with an underlying developmental delay. Okay, if you momentarily start at the beginning itself, beginning of presentation, if you say the child has got phenotypically Down syndrome, then
Yes,
there itself the diagnosis is there.
Okay, sir.
All right. Okay.
Okay, sir.
Right, fine.
I have a question. Sir, are you done, Dr. Ganesh?
Yes, ma'am.
You said the mother and baby were discharged on day 5.
Yes, ma'am.
But what screening tests were done? Surely, when the teams saw the dysmorphic faces, some basic screening tests they would have done.
Yes, ma'am. At birth, they have done echo, ma'am.
Mm-hmm.
Echo, they have told that to the mother that some cardiac defect is present, and they have to repeat after 6 months. And then they have taken USD abdomen, and also they have been advised for karyotaping, and thyroid is done at the birth, ma'am.
Nothing else?
And audiological examination, ear examination is done, ma'am.
Okay. If you had been there, would you have done something more?
Yes, ma'am. I will be examining the eye, ma'am. Along with that, at birth, we will be taking hematological to rule out. We have to take CBC. Along with that, we have to.
Okay. Ear examination is a part of general physical examination. You will definitely do a hearing screening and a complete blood count.
Vision screening.
Yeah. Please continue.
Okay. When baby was taken for vaccination at 1.5 months of age, they are advised to do karyotaping, and karyotaping done and was suggestive of Down syndrome. Thyroid screening done initially at birth, and at 6 months age was normal. Other history, the child now.
Can you tell us what genetic abnormalities can cause Down syndrome?
Genes involved.
Yeah. What genetic defects can
Meiotic
cause Down syndrome?
non-disjunction, ma'am.
Can you list all the genetic abnormalities?
Okay. Most common is meiotic non-disjunction, and another one is translocation, and in that most common is Robertsonian translocation. Other than that, mosaicism is present, and less common is ring chromosomes and isochromosomes. That's one.
So non-disjunction resulting in what? What is the genetic mechanism?
Meiotic trisomy 21.
Exactly. So that accounts for most of the Down syndrome that we see.
Okay.
In this child, was the mother, since she is so knowledgeable, was she able to tell you What was the karyotype report?
Ma'am, actually, she has taken one, but she told she lost it and she told ma'am.
Okay. So, is it important for you? She is 39.
Yes, ma'am.
Has she completed her family?
Yes, ma'am. She completed the family. If not, why we have to the recurrence of Down syndrome can be decided on based on the karyotyping.
So tell me.
Robertson translocation, it's in 21 but comma 21, it is 100%, ma'am. And if in the other cases, if maternal inheritance means it's 15% and paternal inheritance means it's 1 to 5%, ma'am.
No, that you're talking only about 1421 translocation. That is not the commonest kind of Down syndrome. The commonest genetic mechanism is trisomy 21 only. 95% are trisomy 21.
Yes, ma'am.
So given that that is the commonest, what will be the risk?
0.5 to 0.9%, ma'am.
No, it again depends upon the maternal rate. It will be 1% more than whatever it is for the maternal rate.
Okay.
Yeah, please continue.
A child goes to special school with a mother accumulate, studying currently in 9th standard in MIBMED, registered and has a disability certificate since the age of 1.5 years. And at present, child is able to express her basic needs, able to eat without spillage, but needs assistance with tasks like toileting, bathing, and undress herself. She finds difficulty in reading, writing, and but can be able to tell orally and can sing rhymes when reinforced many times. Started playing simple games with other children, but ends up quarreling with her age group, more comfortable with children of higher age. Has behavioral issues in the form of not knowing social manners and picking up conflict and throwing tantrums in public places, and needs to be counseled and persuaded to obey her mother at home. Has sleeping disturbances and wakes up every 2 to 3 hours of sleep and says she feels fearful and then sleeps off when mother soothes her. Child has said to have some cardiac defect when evaluated at 1.5 years of age. An echo followed up after a year and was said to be normal. History of recurrent upper respiratory tract infections present and was treated symptomatically. Approximately 5 to 6 episodes per year and all were treated on OPD basis. No history of previous nebulization. And no one history of hospitalization was present at the age of 5 years of age and was admitted for lower respiratory tract infections and were treated with IV antibiotics. No history of constipation, vomiting, regurgitation of feeds, and no history of seizures, involuntary movements, difficulty while sitting or standing, and no history of bone pain, easy fatigability. Hearing evaluation done at 2 years of age and was said to be normal. And child was noted to have squint in both eyes since birth, and for which she was operated at Shankar Nethralaya at 500 years of age, was prescribed spectacles and on annual follow-up for the same. Developmental history, gross motor, development quotient 23.07, claim stars and alternating. Yes, ma'am.
You have gone system-wise, which is very good, but you have missed out two important systems. What about orthopedics?
Ma'am, there is no bone, no history of any fractures and no history of any difficulty in moving the legs, ma'am.
I'm not aware that these children are more prone to fractures.
Ma'am, the bone mineral density will be less, ma'am. So they are somewhat a higher risk in fractures also, ma'am. And other than that, I have to ask in ligaments instability will be present in them, ma'am.
So the main problem which we are worried about after 4 years is
Atlantaxial
instability. So yes, what will be the clinical manifestations?
There will be neck pain associated with bladder bowel disturbances, and there will be paraplegia, and there will be urinary incontinence.
Very late, na? Initially, there will be gait disturbance and lower limb weakness. So when you're doing system-wise history, you have to include this also.
Okay.
And in the year, otitis media, ENT.
Yes, ma'am. There will be recurrent middle ear infections with serious otitis media will be present, ma'am.
And obstructive sleep apnea.
Okay.
When you spoke about getting up in the night, I was thinking you will elaborate on that, but you missed that part.
Okay.
So complete all the systems when you're doing system-specific history taking.
Okay.
Please continue.
Developmental history. Gross motor claim stars alternate feet going upstairs. Developmental quotient is 23.07 and fine motor scribbles 9 blocks. Its developmental quotient is 23.07. Language sings poems. Developmental quotient is 30.76 and social and adaptive undresses 38.46. So, immunization history, vaccinated according to NIS till 10 years of age. Dietary history, the child consumes 1980 calories against 2400 kilocalories with a deficit of 420 kilocalories per day. And the child consumes proteins of 34 grams against 43 grams per day with a deficit of 9 grams per day.
In this
Family
child, are you happy with her immunization?
Ma'am?
Or would you like to offer her something more?
Ma'am, optional vaccines such as influenza, pneumococcal vaccine is now added in NIS, ma'am. Along with it, varicella can be advised, ma'am.
I am not aware that influenza has come into the national immunization schedule.
No, ma'am, we can advise for additional
Yes.
vaccines, we can advise, ma'am.
Yes, yes.
Oh.
Please continue. And this expected calorie and protein intake, I'm not sure where you got it from.
Ma'am, ICMR, ma'am.
ICMR? Okay,
Yes,
please
ma'am.
continue.
Family history, non-consanguineous marriage, parent karyotyping not done, no history of similar illness in the family, elder sister developmentally normal. Abortion, first abortion is spontaneous and other two abortion MTP has been done. No history of cardiac diseases, thyroid disorders in the family. Socioeconomic history, four
No,
members in
why are you mentioning that parents karyotyping not done? Do you want to do it in every child with Down syndrome?
Ma'am, if a child is a first child and they are planning for the second pregnancy, it is better to do karyotaping also, ma'am.
I will not do it if the child has straightforward trisomy 21.
Okay, ma'am.
In
Because the
classical
recurrence
trisomy
rate, if
21,
a
it
child,
is not.
parents are normal means it's so actually 1%, ma'am. If parents are carrier means the risk is 2.5 to 10%.
It depends upon what kind of carrier they are. But my
Okay.
point is, in a classical trisomy 21, parental karyotyping is not essential.
Okay, ma'am.
Continue.
Socioeconomic history, 4 members in the family, per capita income is 1,500. Parents' education, father is completed high school education. He is working as an electrician. Mother completed diploma. She is a housewife. Lives in a pakka house with 2 rooms and 1 bathroom. Ventilation is good. Municipal water supply, and they belongs to lower middle class according to Modifi Kuppasamy scale. Menstrual history, the child attend menarche at 10 years of age. A regular cycle changes to 3 pads per day. Regular flow, no history of dysmenorrhea, and she requires assistance in changing pads. Last menstrual period is 28th October. Summary, a 13-year-old female child born of non-consanguineous marriage to parents of advanced maternal and paternal age was noted to have dysmorphic features since birth with a history of delay in attaining age-appropriate milestones involving all 4 domains, more marked in gross and fine motor domains with a positive karyotyping report suggestive of Down syndrome. Child currently has refractory errors, no history of suggestive of congenital heart failure, heart disease, and with normal thyroid function, with behavioral and sleep disturbances, requiring minimal assistance in activities of daily living, and child has come for regular multidisciplinary follow-up.
Dr. Rakshana,
Yes, sir.
anything about the growth and this thing? Have you mentioned about the development? Have
Yes.
you mentioned about the child's growth over a period of time? How does she appear? She appears to be short.
Anthropometry, yes, sir.
No, in the history itself, does she appear to be short when compared with the peers?
No, sir. Actually, now she is coming under the normal height, sir.
Okay. I think that one part you should have made a mention. Growth
Okay.
seems to be normal. Height
Okay.
seems to be normal. And second thing about the weight also, because most of these kids, they're
Obese.
on the plumpier side,
Okay.
right? So that also you have to make a mention. That's also
Okay.
most important. And you said why there is minimal assistance in activities of daily life?
Yes, sir.
Why?
So
She's able to
because
do
she requires helps in while dressing, undresses, she requires help, sir.
Okay.
And also you by use while going toilet also she wants to undress because she wants her mother to be with her. So I mentioned minimal assistance.
No, but the point is, this is not minimal assistance. It is a
This
lot
is
of
a
assistance.
lot
Okay.
of assistance she needs. That's what.
Okay.
Dr. Ganesh, I'm not able to hear you very well. Is it only my audio or is anybody else facing the same issue?
Now you are able to hear, ma'am?
It's definitely better than before.
Okay.
Are you using some kind of a speaker, sir?
No,
Microphone?
from the laptop speaker only.
Okay. Please continue, Rakshana.
Okay. General examination. Examination was done after obtaining consent from the parent, and child was active, alert, sitting comfortably in the bed. No pallid ictus cyanosis, clubbing, lymphadenopathy, and edema. Vitals, temperature afebrile, pulse rate is 90 per minute, normal volume and rhythm and character, no radial and no radiofemoral delay, peripheral pulse is well filled. Respiratory rate 21 per minute and
Rakshana,
yes, ma'am.
I'm expecting you to tell at the outset that the child looked dysmorphic. What is the most striking abnormality that you should mention when you start your physical examination?
Child has dysmorphic features,
You
suggestive
can
of
describe them in detail later.
Okay.
But first appearance, it should be mentioned that the child is dysmorphic.
Okay. BP is 100 by 70 mmHg at 50 centile, measured at the right arm in sitting posture, and the CRT is less than 3 seconds. Anthropometry, the interpretation is normal. When I plotted in the down-specific growth charts, all the height, weight, and BMI, height circumference, everything is normal. Head to toe examination. Head brachycephaly, flat occiput, face flat facial profile, eyes upward slant of palpebral fissures, nose flat nasal bridge, ears low set ears and small rounded ear, oral cavity wide open mouth, protruding tongue with small oral cavity, irregular dentition and dental caries present, neck short neck, redundant neck, skin in the nape of the neck, throat grade 2 tonsillar enlargement and skin normal. Upper limb short, broad hands. Simian crease is present in right hand and Sydney crease is present in left. Clinodactyly of the fifth finger. Lower limbs wide saddle gap. Joints hyperflexible joints present and spine normal. Genitalia female phenotype and Tanner staging is SMA stage 4. These are the pictures. Dermatoglyphics, digits, ulnar loops on most fingers, radial loops on fourth and fifth, and palm digital distal radius is present and ATD angle is 50. Systemic examination. CNS higher mental functions, level of consciousness, conscious, speech 2 to 3, speaks 2 to 3 word sentences. Only recent memory could be elicited and right-handed person and behavior is low mood. Cranial nerve examination. Okay. First nerve not tested. Second, visual acuity not elicited. Perceive hand movements. Field of vision not elicited. Color vision able to recognize bright color objects. Fundus is normal. Pupil bilateral pupils reacting to light. Third, fourth, and sixth extraocular movements normal. Fifth nerve sensation over the face is intact. Jaw movements is normal. Seventh, no facial asymmetry. Can close the eyes tightly. And nasolabial floats preserved. 8th turns to sound. 9th and 10th, no regurgitation of feet, uvula and midline. 11th, able to shrug the shoulders and able to turn the head against resistance. Tongue protrusion normal. No hypotonia and wasting fasciculations. Motor system bulk normal, tone normal, and power is 5 by 5 on all 4 limbs. Superficial reflexes, plantar flexor. Deep tendon reflexes, biceps, all reflexes are 2+. Sensory can perceive touch, pain, and temperature. Cerebellum, no involuntary movements, no nystagmus and tremors. Gait normal, spine normal, and no signs of increased ICT and no signs of meningeal irritation. Other systems, cardiovascular system, S1, S2 here, no abdominal heart sounds. RS bilateral air entry, normal vesicular breath sounds, and no added sounds. Abdomen soft, no organomegaly. Diagnosis, a case of Down syndrome with intellectual disability, immunized up to date under national immunization schedule with normal nutritional status associated with history of recurrent upper respiratory tract infections, vision abnormality, no congenital heart disease, and came for routine multidisciplinary follow-up.
So Rakshana, she has come for her routine follow-up.
Yes, ma'am.
In the routine follow-up, what should you be doing for these children? Okay, supposing she has come to you after 1 year.
At 1 year, Amma.
After
at 1 year
year.
of age. At
How
1 year
often
of
do you want these children to come for routine follow-up?
Ma'am, every year, yearly follow-up, ma'am.
Exactly. So if she's come for her annual follow-up, what will you do for her?
At 1 year of age, the child usually at birth, after birth, at 1 year of age, we'll be doing an audiological examination along with ear examination and thyroid we have to do. And then we will be doing.
Doctor, please stop sharing the slide so that you can discuss. Please stop sharing the slide.
Yes, sir.
You please continue the discussion, Dr. Padma. Yeah.
So you said you will do thyroid screening, okay?
Yes, ma'am. Then along with that, echo, thyroid screening and CBC and peripheral smear I will be doing, ma'am. Along with the dental, there will be examination. Along with the growth and development in each annual we will do, ma'am.
Okay. Anything
Growth
else?
and then, ma'am, in boys, we will be doing testicular examination also, ma'am.
In this child, you said the child has a refractive error, but in the photo that you showed, I didn't see her wearing glasses.
Ma'am, that time she didn't wear, ma'am. She
Okay,
removed and
so
she take the photo, ma'am.
so the refractive error can change with every passing year. You have to repeat the optal
Yes,
evaluation.
ma'am. Yes, ma'am. Every year, an examination of ophthalmology and audiology examination should be done.
Yes, and in addition to audiology examination, after the age of 4 years, what will you do? Especially if the child has a disturbed sleep.
Then we'll be if we are suspecting obstructive sleep apnea, then we'll be doing polysomnography to rule out OSA, ma'am.
You will do sleep studies. Okay. Do you have to routinely do cervical spine X-rays?
Ma'am, routine there is not needed, ma'am.
Yeah, it is not needed unless the child has symptoms. But you
Yes,
will
ma'am.
definitely ask for symptoms so that you
Yes.
can pick it up early, isn't it?
Yes, ma'am.
Okay. In terms of management, what can you do for this child?
Ma'am, we will start with the therapies like occupational therapy, and then there will be speech therapy we will be doing. Along with that, we will be doing motor therapy, and with feeding difficulties, if any present, means at birth we will be doing NG tube feeding, ma'am. Other than
No,
that,
please,
only.
no, we are not discussing anything hypothetically. This child is in front of you. She's 13 years old. You have examined her. What do you want to do for this child?
So now main there is occupational therapy, and then will be speech therapy we will be giving, and then we will be doing
You said
main.
she's attained menarche and she's not able to take care of her personal hygiene. Her mother has to do it for her.
Yes,
Is there
ma'am.
anything you can do to help the mother?
Ma'am, we can give prescribe medications, ma'am, but
For what?
actually we can help, ma'am, counsel the mother to help her, ma'am.
But she's already doing without your counseling also. Okay, there are hormonal preparations available. Take the help of your gynecological colleagues. They can
Okay.
reduce the frequency and they can reduce the flow
Okay.
to make it easier for the mother to manage the child.
Okay.
Apart from that, the immunization, which we have already discussed,
Yes, ma'am.
and screening for medical diseases, which are more common in children with Down syndrome. Dr. Ganesh, is there anything you want to add?
Nothing, ma'am. A seemingly well presentation, but only thing is a few with regards to the behavioral therapy. I think she should attend the behavioral therapy classes, and then they should more focus towards this occupation therapy, so that at least we should try her to lead a near normal life as far as possible. That is, the activities of daily life has to be reinforced for her.
Okay.
Sir, SB sir.
Excellent presentation. Very, very well discussed by Dr. Padmasini. Few suggestions to the postgraduate.
Yes, sir.
In the presentation, when you are presenting details of an adolescent girl or boy, do not use the term child. Please use the term adolescent.
Okay, sir.
Comment number one. Comment number two. Do not use the term optional vaccine. This I keep on saying in every PG class. The term optional vaccine was a term which was used a decade back by the ACVIP and the IAP. The term has been removed. It's only an ACVIP or IAP recommended vaccine. There is no question of option. That term is gone, is outdated. It is very similar to weaning and supplementary feeding. We do not use the term optional vaccine. 2. 3, you said that this child, this girl, habits die hard. This adolescent girl, when she was a year, they picked up some abnormality in the echo. Later it cleared. That's what you said. Am I right?
Yes, sir.
Yeah. Now, please tell me, what are the cardiac defects that can be expected in a
The most
case of
common is
Down syndrome?
atrioventricular septal defect, sir. Next one is
What do you mean by atrioventricular septal defect?
endocardial cushion.
What are the defects that you can get when there is an atrioventricular septal defect? What are the anatomical lesions that you can get when there is atrioventricular septal defect?
Like atrioventricular septal defect will be left to right shunt.
Left, right shunt. What are the lesions? Which is most common?
VSD.
Yeah. What type of VSD you get in Down syndrome?
Perimembranous.
Perimembranous. What are the anatomically, fundamentally, embryologically, what are the types of VSD? Anatomically, not on the site, on the pathology.
Muscular or
See, AV canal defect can get. You can get an AV canal defect which can cause VSD, a ostium primum defect. The correct answer is it's an ostium primum defect.
Okay.
If it is an ASD, okay, or a VSD. And it can be a combination of ASD, VSD, and also
very rarely we will be getting TOF and PDAs.
mitral regurgitation also.
Okay.
Okay. And can you diagnose this with the ECG? The specific cardiac defect you can swear it is ostium primum defect with one finding in the ECG. Can you tell me which finding? Left axis deviation.
Okay.
Usually, you all normal children have right axis in the early years. So you find a left axis deviation is very characteristic of an ostium primum defect.
Okay.
Right? And I'm surprised that in a child with Down syndrome, spontaneous closure has occurred, which is very, very rare. Not common, but you can have anything in any disease.
Okay.
That is one question. The other comment that I wanted to make, was of course Padmasri very clearly mentioned. I think the first sentence in the examination should be only on the general appearance of the child and what is alerting your attention and what is arresting your attention. I think the opening statement is very, very crucial, not only in the exam, but also in any meeting to get home the message. Whatever that is striking, here is a child who has all the features of Down syndrome at the very look of it. Right?
Yes.
So that is one thing. Last two more questions I've got to, I wanted to ask. Okay. One, a child with Down syndrome comes with frequent urination.
Okay.
Child with Down syndrome is a very common complaint. You can, if you see 100 Down syndromes, 50 of them will have this complaint. Frequent urination. What is the differential diagnosis specifically in Down syndrome when a child comes with, say, enuresis or frequent micturition?
Sir, actually, urinary incontinence can be present in atlantoaxial in the subluxation, and in boys, the hypospadias will be present.
No, there is no atlantoaxial dislocation, but there is renal urinary problem. Okay, atlantoaxial, you said right.
And then there will be hypospadias, hydroureter nephrosis will be there, sir.
Something more common than this.
Yes.
Bowel bladder dysfunction is very, very high in incidence. Like GERD, very high in Down syndrome because of hypotonia. Bowel bladder dysfunction is frequent. Constipation is very, very elimination problems. Elimination problems are both constipation as well as enuresis are very common in Down syndrome, often neglected. But they may not give you symptoms of pain very well like normal children. That's it. The other problem is significant percentage of Down syndrome may also have spinal anomalies.
Oh, yes.
Spinal. That may the child may present with enuresis and may turn out to be a spinal anomaly other than the cervical, brainstem lesions occurring due to atlantoaxial dislocation. They may also have spinal abnormalities. Of course, my last question is, you said the father's age is high.
Yes, sir.
You know Down syndrome, you will blame the mother's age. How can father's age be responsible for a few syndromes? Give few examples.
For father's age, it's achondroplasia, Apert syndrome, Krausen syndrome, and P. Pfeiffer syndrome. And also in Down syndrome, if more than 40 years is there, there will be defects in the DNA replication in the sperms, which would be responsible for ADHD and all.
Okay. Other than this, please do not forget Klinefelter syndrome
Okay,
and Engelmann syndrome.
Okay.
Okay, these two are even you said rightly achondroplasia, etc. But don't forget Marfan syndrome. Marfan syndrome also is high paternal age, and then you rightly said craniosynostosis. What did I say? I forgot what I said. Sorry. The other thing is Engelmann syndrome, and of course achondroplasia is well known.
Yes.
Marfan syndrome is well known. Okay, right. And in addition, you mentioned what are the orthopedic problems in Down syndrome?
So there will be
other than Atlantax.
There will be
what is the orthopedic problem?
Slipped.
Pardon? Basically, you must remember. Basically, like see, it's very
upper
common.
Femoral epiphysis, sir. Or subluxation and dislocation is most common, sir. And then
see, any child who has hypotonia or what you call hypermobility syndrome, like Down syndrome, Ehlers-Danlos, Marfan, they are all prone for frequent dislocation. In fact, you will find that many a child with Down syndrome will come to your clinic with pseudo-paralysis due to pulled elbow. Very, very frequent. Very, very frequent. That's the most common orthopedic problem in Down syndrome. Okay? Otherwise, excellent presentation. Very well done. Very well done. Thank you.
Thank you, sir.
Thank you, sir. Dr. Rakshana, the take-home message is for the PGs is I think you should look at the child not medically alone. You should look at the child socially, what you are going to do for the child. Even my PGs will write complaints of the child is brought for known case of Down syndrome. So all these things we have to, when you become a consultant, you have to look at the child socially. These children should take care of themselves when they have become adult. So we, as a pediatrician, we are responsible for them to make that happen. So we should look at the child socially. That's what all the mentors wanted to convey. Thank you for your presentation. Dr. Kokila, can you share your screen? We'll start with the next case, Rickets. We are on time.
Yes, sir. Yes, sir. So shall I start, sir? Sir, shall I start, sir?
Yeah, start, doctor.
Yeah, start. Can you put it as a slideshow?
Yes, sir.
Yeah, now it is a slideshow. Thank you. You can start, madam. Yeah, madam, can we start, madam? Padmaswini, madam?
Yes, sir. Please.
Please, we'll start.
Sir, good evening, everyone, sir. I thank you for giving me an opportunity to present in this forum. I'm Dr. Gokila, final year DNB Pediatrics resident from Department of Pediatrics and Neonatology, Dr. Kamakshi Memorial Hospital, Chennai. Today, I would like to present a case of 1 year, 10 months girl child who presented to pediatric OPD with complaints of abnormal bowing of legs for the past 5 months. History of presenting illness. History of outward bending of legs. Notice child started to walk. There was history of delay in walking when compared to her 2 elder siblings. Child started to walk at 1 year, 5 months of age. Parents noted abnormal bowing of leg and parents noted abnormal walking. Hence, a parent took the child to beach stand to make her walk in the beach stand so that she will get a good tone of the lower limb. and they even buried her legs in beach sand initially for 1 or 2 months. But there was no improvements. Hence, child was taken to physiotherapist for the above complaints, and the child was started on home physiotherapy by parents themselves. But there was no improvement. The abnormal bending was progressively increasing. Hence, the child presented to a hospital for further evaluation. There was no history of frequent falls noted while child was walking. There was no history of delayed dentition. There was no history of seizures. No history of excessive forehead sweating during infancy. No history of decreased activity. Child is found actively playing with a sibling and peers of her age. And the bowel and bladder habits were normal. There was no history of polyuria, no history of loose stools or oily stools, no history of recurrent respiratory tract infection, no history of visual or hearing disturbance. The child was exposed to sunlight less than 30 minutes per day, and she was not allowed to play outdoors. As medical history, there was no
Can we go
previous
here?
illness.
Can we pause?
Yes, ma'am. Yes, ma'am.
Mother will definitely be concerned, but are you concerned when there is outward bending of the leg in a 1 year, 10-month-old child? Because according to you, everything else is normal.
Normal toddler walking, they can have bending of legs, ma'am.
What is physiological genoverum?
The physiological genoverum, less than 2 years child, they can have outward bending of legs due to the growing bone and
So the only thing which is a little causing concern is the child has not started walking. There is a developmental, there's a mild delay in beginning to walk, but the child has independent standing, right?
Yes, ma'am. Yes, ma'am. Independent standing. Yes, ma'am.
Okay. No, I just want you to keep in mind the physiological verum
Yes,
that
ma'am.
children have typically at 1 year of age. It may increase till 18
Yes,
months and then it resolves by 3 years. And after 3 years, they may even have genu valgum. Normal alignment we
okay.
expect only between 6 and 8 years of age.
Okay.
Before you rush
Yes,
in to
ma'am.
investigate children with genu varum, you have to find out whether it is progressively increasing or whether it is getting better.
Okay, ma'am. Okay, ma'am.
Please continue.
As medical history, there was no previous illness requiring admission, any respiratory illness or other illness, no history of drug intake, and no surgical history. Antenatal history, the child is third child born
No,
of
I want you to
non-consanguineous
ask
marriage,
specific
spontaneous
questions. No, you cannot put everything saying no previous
Yes, ma'am.
illness. In this child, before you decide what is the cause of the bending of the legs, I would like you to ask very specific questions. What all medical illnesses should you rule out?
Plus, any renal illness in the form of polyuria or frothy urine, history of frothy urine, history of polyuria, liver disease or malabsorption syndromes like history of recurrent loose stools, oily stools, history of poor weight gain, ma'am.
Yes, I would like you to present in detail all renal history and hepatic history, fat malabsorption history in a child who at the age of 1 year, 10 months is developing bending of the bones.
Yes, ma'am.
You want marks in your basket. You have to highlight your knowledge.
Okay, ma'am. Okay, ma'am.
Please continue.
Okay, ma'am. To rule of between nutritional care, I would like to ask is pertaining to renal system.
I don't know,
whether the child is
maybe it is.
having a body urine.
So, okay, please continue. Did I miss this? Did you present this earlier? I'm sorry, I seem to have missed this. Please continue.
Okay, ma'am. Okay, ma'am. There was no recurrent respiratory tract infection. There was no history of recurrent loose or oily stools, and there was no history of polyuria. And there is no history of visual or hearing.
If you have presented this and I have missed it, I apologize. You skip this and you continue with your presentation.
Okay, ma'am. Okay, ma'am.
I would like to continue antenatal history. The child is third born child out of non-consanguineous marriage.
Your slide is not
Conception.
moving.
Antenatal scans were normal. There were
Okay.
visible slide.
Now your slide has moved, but your audio quality is not great. When you started off, we could hear you clearly, but now your voice is dropping.
Can you able to hear me, ma'am? Shall I?
Yes.
Shall I
Yes,
start?
please continue.
Third born child out of non-consanguineous marriage, spontaneous conception. Antenatal scans were normal. There was no comorbidities in mother. Mother received iron, folic acid, and calcium supplements during antenatal period. Complaints of drugs were good during antenatal period. Mother has taken calcium, but only for 2 months postnatally. And she didn't take any calcium tablets after 2 months of delivery.
But why are you
Natal
highlighting
history,
all this?
The child is 30.
Kokila, why are you highlighting all this?
ma'am.
This is a
Everything-
short case, so you take a focused history. Do you think there is any connection between mother not taking calcium during pregnancy and the child developing some bending of the legs at 1 year, 10 months of age?
No, ma'am. No, ma'am.
If there is no connection, then don't highlight all this in such great detail.
Okay,
Move
ma'am.
on.
Okay, ma'am. Yes, ma'am. Natal history, no, child born normal vaginal delivery and normal natal history and postnatal history. Child had history of hyperbilirubinemia, received phototherapy for 1 day, no history of neonatal seizures, no neonatal hypoglycemia or hypocalcemia. Development history, there is no developmental delay. Gross motor, a child attained head control at 4 months. She rolled over at 5 months. Sits with support at 6 months, sits without support at 8 months, stood alone at 1 year, but stood alone without help at 1 year, 5 months. And fine motor milestones,
Your
mouth
slide is not
objects were
moving.
noted from 6 months.
Doctor, your slide is not moving.
And we don't want these milestones monthly. We just want you to tell us your assessment. If there is no delay, we will move on. If we want details, we will
There
ask
was
you.
no developmental delay, ma'am.
Yeah, so till 1 year of age, everything was normal.
Yes, ma'am. Yes, ma'am.
Oh, she was able to walk by 1 year, 5 months. Okay, that's good. Please continue.
Yes, ma'am. She was able to walk by 1 year, 5 months. No, ma'am. Development is normal, ma'am.
Doctor,
And
she's able
diet
to
history,
indicate.
child was exclusively breastfed for.
I am not able to hear her well. Dr. Ganesh, are you
No,
able to
ma'am.
hear her?
I am also trying to tell her. We are not able to hear at all. If the slides move, we are not able to hear her. Or if she's able to, if we are able to hear her well, then the slides are not moving.
Gokila, move the slide first and then you please talk. Can you hear us?
Sir, can I able to hear me, sir?
Yeah, with some interruptions. Okay, please try to continue. We'll see. We'll let you know.
Sir, can you able to hear me, sir?
Yeah. Now it is better.
Now it is clear.
Now it's clear.
Yes, sir. Diet history. Child was given exclusive breastfeeding for 6 months and complementary feed started since 7 months of age. Breastfeeding continued till 1 year.
Gokila, this is a dramatic
ma'am.
improvement in the audio quality. What did you do differently?
Ma'am, I changed the place, ma'am.
Excellent.
Place
Please
of-
continue in the same place. Yeah.
Okay, ma'am. Yes, ma'am. Child was given exclusive breastfeeding for 6 months and complementary feed started since 7 months of age. Breastfeeds continued till 1 year, 6 months of age. Child was started on complementary feeds from 7 months with ragi kanji, rice Bengal gram kanji initially followed
Gokila,
by.
we really don't want to know the specific details.
If you want to
Okay,
tell us,
ma'am.
you tell us whether the minimum meal frequency and the minimum dietary diversity was attained. Otherwise, you just tell
Yes,
us whether
ma'am.
the child was taking adequate amount of calcium and whether
Yes, ma'am.
vitamin D drops were being given.
Okay, ma'am. And the child was taking adequate calories and protein, but vitamin D drops was not given for the child from 6 months of age, ma'am, which was recommended to continue. Child was not given vitamin D drops.
Okay.
And the family history, she is born out of non-consanguineous marriage and no family history of short stature or similar illness. And her both elder sibling walked at the age of first birthday, 1 year, ma'am.
Okay.
Good.
Socioeconomic history, the child belonged to upper middle class socioeconomic status. They were living in a pakka house with child was living in first floor with two bedroom hall kitchen with two windows in each room, window not tinted and chance exposure inside home was present. Father is engineer by occupation and mother is a homemaker. So to summarize from the history, she is a third-born girl out of non-consanguineous parentage with normal antenatal, natal, postnatal developmentally belonging to upper middle socioeconomic status, presented with abnormal outward bowing of legs and abnormal gait for further evaluation.
So, Doctor, what are the possible
With this, I would like
differential?
to start my examination.
Dr. Gokila,
Yes, sir.
with your history, what do you think is the probable differential
Yes, sir.
diagnosis? What is the probable differential diagnosis at the end of your history taking? This child has presented with bowing of legs, right? Development
Bowing
is
of legs.
normal.
She
Yeah.
is presented with bowing of legs with normal.
So,
So
what are all the
she
differential
can be a normal toddler.
what are all the differential
It's a normal
diagnosis?
toddler bowing. Rickets, sir. First diagnosis is rickets. Probably nutritional rickets.
Okay. Any other?
And other we consider metaphyseal dysplasia, sir.
Okay. Any other? This was discussed earlier by madam. So the physiological bowing also can
Sir?
occur in this age group.
Physiological norm. Okay, sir.
Okay. Right.
Okay.
Proceed.
Okay, sir. On examination, child was cheerful, actively playing with toys and cooperated with the examiner for clinical examination. On general examination, she was not pale. She neither had ictus nor cyanosis, no clubbing or no generalized lymphadenopathy noted, no pedal edema. On head-to-toe examination, there was frontoparietal bossing, anteronternal was closed, hair texture and color were normal, eyes normal, cornea clear, no cataract or, sir?
Sorry, your slide did not move. That's what I wanted to say. Fine, now it's fine. Proceed. Proceed.
Frontoparietal bossing was, yes, sir. Frontoparietal bossing was present. Anterior fontanelle closed. Hair texture and color was normal. Eyes normal. Cornea clear. No cataract. Oral cavity, upper and lower 4 incisors and molar tooths were present. There was no abnormal dentition. Neck normal. Chest normal. There was no rachitic rosary. No Harrison sulcus or chest wall deformity. Abdomen normal. Umbilicus normal. Upper limb, there was widening of both wrist and lower limb, bowing of legs, genu varum was present, and the entire condylar distance was 10 centimeter. This is bowing a clinical picture of the child where we can note bowing of both lower limb. Her vital signs were stable
the
and
clinical
anthropometry,
picture,
she was appropriate for her weight
Dr.
height.
Gokila, the clinical picture.
Sir.
Can you just focus on the clinical picture?
Yes. Yes, sir. Child had bowing both genu varum, bowing of both legs, sir.
Okay.
Double malleoli was present in the left side, sir.
Okay. The widening of the wrist is there. Have you taken photograph of the wrist?
Yes, sir. Widening of wrist was present. In next video, I have one video, sir.
Okay.
In that we can see.
Can you just show it if it is possible?
Yes, sir. Sir, in this video, can you, sir? Is it visible, sir?
No, I think your
No.
internet connection is little unstable, but there is a short delay of your screen and what it is visible for us. Now it is visible. You proceed. Proceed. Can you play it once again?
Yes, sir. Widening of wrist. Yes, sir.
Okay, it is little difficult to appreciate. It's okay. You can continue. Ganesh, can we continue?
Yeah, yes, Prasanna, please.
Okay.
And the anthropometry of the child was normal. The child weight, height, and head circumference were between -1 and -2 standard deviation, and BMI is appropriate for age. And systemic examination, respiratory system was normal, no vesicular blood sounds heard, no added sounds, cardiovascular.
Dr. Gokila, 1 minute.
Yes,
how did
ma'am.
you measure height of this girl?
So stand 1 year 8 months with infantometer, sir.
Okay. So, but when there is
With infantometer, sir.
such a bony deformity is there, is it possible that you can check?
Yes, sir.
Or you have taken a segmental length?
No, sir, we holded the feet and checked
When
the
there is a
height, sir.
gross deformity or contractures, you are supposed to say take the segmental length and then you are supposed to add. Because when there is too much of bowing, I think you will not be able to measure exactly the length by using your infantometer. Okay.
Okay, sir.
Right.
Okay, sir.
Fine. Proceed.
Okay.
Proceed.
Madam,
Can you tell us how you took the intercondylar distance?
Ma'am, with the child in supine position, ma'am,
Okay.
the is measured between the medial condyles of femur, ma'am.
Before you measure, you have to place the limbs in proper alignment. How did you place the lower limbs?
The medial malleolus are brought together.
Yes, the patella should be facing forward and the medial malleoli should be touching each other. And then you find the distance between the medial femoral condyles.
Yes, ma'am. Okay, ma'am.
Okay, please continue.
Systemic examination, respiratory system, sounds heard, no added sounds, cardiovascular system, normal heart sounds heard, no murmur, abdomen was soft, not distended, no tenderness, umbilicus was normal in position, no organomegaly, hernial orifices were free, and genitalia was normal. Central nervous system, higher functions normal, there was no cranial nerve palsy, motor system was normal, gait, child had a waddling gait, that was in this video, ma'am. Otherwise, normal central nervous system, ma'am. So,
When you want to
coming
show
to the
waddling gait, will you take video from the front? Gokila, when you want to demonstrate waddling gait, from where should you take the video of the child's gait? It is best taken from the back, isn't it? You can see the way the hips, the pelvis is dipping when the child is walking. In this video, I'm not able to say for sure that there's a waddling gait. I'm just telling you for future reference. Please continue.
Okay, ma'am. Okay. Yes,
actually,
yes.
that is looking more like a GIF, madam. Actually, because of presentation, I think she has converted into a GIF. Okay, Pak, you continue.
Yes. coming to the diagnosis, third born girl child born of non-consanguineous parentage with normal antenatal, natal, postnatal development history belonging to upper middle socioeconomic status, presented with abnormal outward bend of legs and abnormal gait, found to have frontoparietal bossing, widening of wrist, genuvera, badly gait, with normal general and systemic examination, normal anthropometry for age. Hence, I would like to offer the provisional diagnosis of rickets, probably nutritional rickets.
Dr. Gokila, this is not a normal general examination, right?
Yes,
All
sir.
you have so many deformities in the general physical examination. There is widening of the wrist, there is bowing of the legs, right? There is frontoparietal bossing is there. So the general examination, it's not normal here. Okay. Probably the systemic examination, the respiratory, cardiac, abdomen, and CNS may be normal, but the general examination is not normal. All are general examination findings only. Okay. So with this, you are considering the differential diagnosis of rickets. So what is the probable etiology would you like to think on this patient? What is the probable cause?
Probably nutritional rickets, sir.
Okay, nutritional rickets due to?
So child have been given, child is not exposed to sunlight and not given vitamin D drops properly.
Okay.
And her regular intake of milk is also less than around 100 ml per day. And I feel it mostly be nutritional, maybe due to vitamin D deficiency.
Okay.
Low calcium intake, low vitamin D intake.
Suppose if this child had pallor, her stature is short for age, and she has got predominant deformities in the lower limbs, what is your probable etiology would you like to think in this patient? Child has got significant pallor.
Any renal cause, sir?
Okay. Okay, fine. So what investigation?
Renal.
Hello? Not able to hear you.
So for this child, I would like to go. So for this child, I would like to go with investigation blood count, serum calcium, phosphorus, alkaline phosphatase with vitamin D level and of wrist and both volumes.
Your voice is interrupting, Dr. Gokila. Can you repeat what you said?
Sir, for this child, I would like to go with complete blood count, serum calcium, phosphorus, alkaline phosphatase, vitamin D level, 25 hydroxy vitamin D level, and with X-ray, sir, radiology X-ray wrist, sir.
Okay. Would you not like to do parathyroid hormone?
Yes, sir. I will do, sir. Parathyroid hormone also,
okay.
Sir.
So your diagnosis was nutritional rickets, right? Yeah, probably
yes,
a calciopenic rickets. So what will be the biochemical parameters in this condition? What do you expect in a serum
she
calcium
will have
phosphorus?
Yes, sir. Serum calcium will be low, sir, and serum phosphorus will be low or normal, sir. Vitamin D will be 25 hydroxy vitamin D levels will be low. Parathyroid hormone will be increased, sir.
Okay. And what about the alkaline phosphatase?
It will be increased, sir. Alkaline phosphatase will be increased, sir.
Okay. Fine. So how do you treat this if it is a vitamin D deficiency?
She is 1 year.
Sir,
Yes, sir.
So, Dr. Ganesh, shall we see the investigation reports if she has them?
Yes, ma'am.
Do you have the reports, Kokila?
Yes, ma'am. Yes.
Can you share?
Child, yes, sir. Child had serum calcium 8.6 milligrams per deciliter, serum phosphorus 2.4 milligrams per deciliter, serum alkaline phosphatase 1713 units per liter, 25 hydroxy vitamin D level was 5.64 nanograms per ml, ma'am. Parathyroid hormone 423.5 picograms per ml. So
what is the relevance of complete blood count here?
Ma'am, a child was not pale, ma'am, but we want to see whether anemia is present and all 3 cell lines normal.
Is there any relevance in a child with rickets? I think Dr. Ganesh already made a point about pallor.
Yes, ma'am. Yes, ma'am. Renal rickets la anemia இருக்கும் ma'am.
Yes.
Yes.
Child may have anemia and renal rickets, but if it is severe, general examination like தெரியும் ma'am.
I
She will
don't
be pale.
I don't trust my general physical examination. If it's less than 7, we can make out. 7?
Okay ma'am.
Yeah. Okay. Do
Okay
you have
ma'am.
any more investigations to share?
Yes ma'am, I have x-rays of the
Sure.
wrist ma'am. So child had cuppings, playing of metaphysis, widening of metaphysis, and osteopenia ma'am.
Gokila, why did you do a
Ma'am?
lateral view? Why did you waste money? Can you tell me what added information you got from the lateral view?
No. AP view is enough ma'am.
Yeah, at least in future, please don't take unnecessary lateral. If you're suspecting some
Okay
kind of a
ma'am.
fracture which cannot be seen in AP view, perhaps you should go in for a lateral. But for diagnosing rickets, just an AP view.
Okay ma'am. Okay ma'am. Okay ma'am.
Yes, there is definitely fraying, flaying, and cupping. And you said something about osteopenic bones,
Yes ma'am.
and the bone age
We
is
can
normal.
see. Ma'am?
Is the bone age normal?
Yes ma'am. 1 year 10 months girls has 2 carpal bones ma'am.
Okay.
Bone is normal ma'am.
Okay. Please continue. Sir, now you have
Yes,
the
ma'am.
diagnosis. Sir was asking you the management.
Yes ma'am. Sir, I would like to start
Do
the
you have,
child on vitamin D
Gokila, if you have
supplementation.
anything more to show us, you show. Otherwise, you stop sharing your screen. Do you
Okay
want to
ma'am.
show us
I'll
anything more?
stop here. No ma'am, treatment slide da ma'am irukku.
Oh, you already put it up as a slide, is it? Okay. Tell us what you did for the child.
Yes ma'am. Yes ma'am. Okay ma'am. Child is started on oral calcium 50 milligrams per kilograms in 2 divided doses, and child is started on vitamin D supplementation 60,000 international units in one sachet every 15 days, once in every 15 days in 30 ml of milk, and the dates were given for the child. And we have given a diet chart, and we have educated the parents regarding foods rich in vitamin D, calcium, phosphorus, and we have given her a diet chart, ma'am.
That is very good. But
Thank
what
you.
are the dietary
Thank you, ma'am.
sources of vitamin D?
Ma'am, vitamin D is present in fish, ma'am, salmon fish, sardines, tuna fish, and sunlight exposure, ma'am. The child should be allowed to play in sunlight 15 to 30 minutes per day, at least 5 days a week, ma'am. And the
I would
child
not
should
depend
be
upon
should
diet. I would not
yes, ma'am.
depend upon fortified milk and eggs and fish and ragi. I would
Yes, ma'am.
depend more on supplements.
Sunlight, yes, ma'am.
Yeah, please continue. When did you repeat the X-ray?
After 1 month, ma'am.
After just 2
Weeks.
doses of vitamin D, you repeated an X-ray. Yeah? When are you supposed to repeat the
Yes,
X-ray?
ma'am. From 4 weeks, 12 weeks, we can repeat the X-ray, ma'am.
I don't think
Biochemistry
so.
after 12 weeks, ma'am.
No, biochemistry, I will expect it to improve in 4 to 6 weeks, but radiological improvement, I will expect only after 6 to 12 weeks. Why unnecessarily do it early and feel worried if the line of calcification has not appeared? I'm not sure. Dr. Ganesh, your
Usually we
thoughts?
repeat after the course of treatment. That is 4 to 6 weeks after starting treatment. That is what we do repeat. And
Okay,
that is
sir.
why where we can see all the
Yes.
signs of healing, like the zone of provisional calcification and the cupping and fraying reduce, and the metaphyseal widening also improves, and the sclerotic healing lines becomes visible by that time. So generally 4 to 6 weeks, by which time the child would have completed at least say 50% of the treatment.
Okay.
Okay, sir. Okay, sir.
And the 60,000 international units every 15 days, I am not saying it's incorrect, but do you have any
Yes, ma'am.
guidelines for this?
Ma'am, more than 1 year, it is preferred 3,000 international units per day for 12 weeks, ma'am.
Yeah,
Once
that's
daily
what we
oral for
normally
12
do.
weeks.
Yeah,
Yes, ma'am.
3,000 to 6,000.
Yes, ma'am. Alternative regimen is 60,000 international unit alternate weeks, ma'am.
Okay.
Fine, doctor.
And above 1 year, you can just straight away give 500 milligrams per day of calcium, elemental calcium.
Yes, ma'am.
So did you repeat any biochemical parameter as well?
No, ma'am. We didn't repeat that.
Okay. Clinically, what did you notice?
Clinically, the child was walking with the paddling gait only, ma'am. And there was bowing. But
I'm not expecting the bowing to change
Yes,
very
ma'am.
dramatically in
Yes,
6
ma'am.
weeks, but the waddling should have resolved if it is because of muscle weakness.
Not
It didn't-
much of clinical improvement, ma'am. She was like same only. She was
Okay, you
walking.
finish your presentation. You finish your presentation and stop sharing before
Yes,
we
ma'am.
continue with our questions.
Thank you, ma'am. Yes, ma'am. Thank you, ma'am.
And what is that synergy symbol on the top?
Our hospital symbol, ma'am.
Okay, no, I was not aware. Okay, that's fine.
Dr. Gokila, suppose in this patient, your vitamin D was low
Yes.
and your PTH was high. Suppose if I give you the scenario where this girl's vitamin D was normal and PTH was very high. So what are the possible differential diagnosis would you think? The same age group, right? You are doing vitamin D. Vitamin D comes as normal, but you see the parathyroid hormone, it is high. So what are the possibilities will you think of? Assuming the serum phosphorus to be normal to low.
Hypophosphatemic rickets, sir.
Hypophosphatic rickets, phosphorus will be low, right?
Yes, sir.
But in this case,
Vitamin D levels can be
not so
known.
low.
Yes.
Not so low. And use
Isolated parathyroid hormone high. Parathyroid adenoma.
no. What is the type of rickets I'm asking? I'm not going to the etiology. See, one thing,
Okay, sir.
this girl presented with rickets, right? You
Mm.
had low calcium, now low phosphorus, alkaline phosphatase
Mm.
was high, vitamin D was low. So you made a diagnosis of vitamin D deficiency, you're treated. Right? Fine.
Yes,
This girl
sir.
did not have any pallor and phosphorus was not very high. So you did not think in terms of a renal etiology. Suppose if I give you the
Yes, sir.
scenario, the same patient, if the vitamin D level was normal, right, and parathyroid hormone levels were
Yes.
high, and you're still suspecting rickets, what is the probable etiology will you think of? What calciopenic rickets will you suspect?
Vitamin D resistant rickets, sir.
Vitamin D resistant rickets you will think of. Okay. Right.
Yes, sir.
Fine. So suppose if the phosphorus levels is too low and parathyroid is normal to slightly high, what will be the possible causes?
Hereditary hypophosphatemic rickets.
Hypophosphatemic rickets, where the
With
treatment changes to you have to
hypercalciuria.
supplement what?
Yes, sir. In
Oral?
hereditary hypophosphatemic rickets with hypercalciuria, we should the etiology is because of sodium and phosphorus channels, sir. So there will be renal excretion of phosphate and 125 we should give calcitriol, sir.
Okay. So what is
Phosphate.
Okay, this girl
Phosphopenic. So we should give phosphorus supplements, sir.
Yeah, phosphorus supplement should be given for this condition. Okay,
yes, sir.
Fine. This girl presented with only bowing of the legs. So suppose if there is a varus, what is windswept deformity?
Windswept deformity is varum of one leg with valgum of the other leg, sir.
Okay, that's fine.
So, yes, sir.
And how do you differentiate? Suppose if this girl has got rachitic rosary, right?
Mm.
This girl did not have.
Yes,
Suppose
sir.
presume that this girl had rachitic rosary. How do you differentiate between a scorbutic rosary, that is the scorbutic rosary, which is due to deficiency of vitamin C?
Okay, sir. A scorbutic rosary, the angulation will be sharp, sir.
Okay.
In rachitic rosary, the angulation is not sharp and it will be painful, sir.
Okay. Fine. Fine.
Sir,
Fine.
sir.
Yeah, that's okay, doctor.
Okay.
Sir, SP sir, any other questions from your side, sir?
Excellent presentation and discussion. Few comments, Dr. Gokila.
Yes, sir.
Though I'm not seeing the good video of the child. If you show me the picture once more, I'll tell you. Please show me the picture of that child's chest
sir.
and limbs, because I'll tell you there are few other findings in the child. One, there is a funnel chest in the child. I could see a sternal depression. One, two. In the side,
Okay.
I think there is Harrison sulcus. Please watch carefully.
Okay.
And I am sure
Okay,
there
sir.
will also be rachitic rosary in this child. Well, because you just
Okay,
give me the picture. So you can't
I'll
afford to miss
I'll
those
show the.
findings. Yeah, please, you can't afford to miss those findings. That's one.
Okay, sir.
The second, you have given 50,000, right? Fine. In the modern days, the so-called STOS therapy of giving 60,000 units, 50,000 units in pediatrics has almost been given up. As a
Okay, sir.
pediatrician, you must be aware of one concept of giving a cumulative dose of probably 3 lakhs is enough. There's no need to give it fast, because if you give STOS therapy, there is always a risk of hypercalciuria and even renal failure cases have been reported. So STOS therapy is no more recommended. Daily therapy, as you pointed out, 3,000 units per day is good enough. And you must also understand the rationale behind calcium administration. Even if the calcium is normal, you're supposed to give calcium mainly because you want to avoid what is called hungry bone syndrome. When you give vitamin D, all the calcium from the serum is pushed into the bones. The child may develop hypocalcemic seizures during therapy if you don't give calcium supplement. That is two.
Okay, sir.
Third, in terms of monitoring for improvement, as Dr. Padmasini clearly pointed out, only monitoring calcium, phosphorus, alkaline phosphate is good enough. And suppose I were to ask you which one returns first, which one returns to normal last? Calcium, phosphorus, alkaline phosphate. Which one returns to normal fast? Which one returns to normal last? Standard example.
Calcium first, sir. Calcium first, sir.
Okay. Second.
Calcium.
Second.
Second.
Same calcium, phosphorus,
alkaline phosphate.
Alkaline phosphate takes very long time. It may take even up to 12 weeks for it to return to normal. Okay. And sometimes X-ray changes also may not occur in the first 4 weeks. As Dr. Padmasini said, they no need to do X-ray. If the biochemical parameters are improving, you can do it at the completion of therapy. Okay. And another standard in your presentation, you made a diagnosis of nutritional rickets. I'm afraid there is no entity today in 2025 called nutritional rickets. That term is outdated. Now, rickets is only classified into 3: calcipenic rickets, phosphopenic rickets, and rickets mimics. These are the only terms today in modern rickets discussion, right?
Okay, sir.
It's no more called nutritional rickets. That term is outdated, right?
Okay, sir. Yes,
The
sir.
reason is very simple. The reason is very simple. You can have vitamin D deficiency rickets even if food is even food intake is good, but you're not exposed to sunlight and you're not given vitamin D supplement. So it's no more called nutritional rickets. The term is gone, right? It's only calcipenic,
Okay.
phosphemic, and rickets mimics. My last question is, what are the rickets mimics that you know of? Rickets mimics. What are the conditions which mimic rick? You got the picture, Mai? Can you show the picture once more?
Yes, sir. I'll show. Yes, sir. I'll show, sir.
Yeah. Last question. Sorry, I don't want to bombard you with
Yes,
more
sir.
questions. Rickets mimics, standard exam question. What are the rickets mimics you know of? What are the common rickets
Sir.
mimics? What are the uncommon rickets mimics? Okay, to save time.
Metafacial dysplasia, sir. Metafacial dysplasia, sir.
No, see, any question like this, you answer from common to uncommon. Commonest is physiological bow leg. You go to the picture of the child.
Yes, sir.
Yeah. Yeah.
Yes,
Yeah. No, focus. No, just focus. See, there is no, not this. The previous film.
Yes, sir. Yes, sir. Yes, sir.
No, the one showing the chest.
One showing the chest. Yes, sir. 1 minute. Yes, sir.
The screen is not moving. Okay, as you get it,
Yes, sir.
the commonest rickets mimic is only physiological bow leg. Number one is physiological bow leg. Okay, but I have seen vitamin D toxicity
Yes.
in normal bow legs children. Somebody giving Arakital 6 lakhs weekly. You just see. I'm sure Ganesh and Padmasini would agree.
Yes.
There is a Harrison sulcus and there is a funnel chest. Ganesh.
Yes, sir.
Yeah.
Harrison sulcus is visible, sir.
Yeah, and another thing, I don't know if the umbilicus is protruding and there is a small hernia and abdomen is distended. They have, of
Child
course,
has got protuberant abdomen. I think
protuberant abdomen. These are all subtle findings, so you can't afford to miss. Okay.
Okay, sir.
Right.
Mm-hmm.
Coming to
Okay,
rickets mimics, commonest is physiological bow leg.
Okay, sir.
Second is Blount's disease.
Blount's, yes, sir.
Okay. Third, as you rightly said, metaphyseal dysplasia, chondrodystrophy, etc. Fourth
Okay,
is,
sir.
of course, hypophosphatasia.
Yes.
Where
Yes.
everything will look like rickets, but alkaline phosphatase won't be elevated.
Elevate. Yes, sir.
Okay. But you can include few other conditions like, children who have hypermobile joints. They also tend to look like having rickets. Right?
Yes, sir.
Even pseudo-rheumatoid disease, there's a dysplasia called pseudo-rheumatoid that also will look like rickets with the widening of the wrists and all that. Right? And
Yes, sir.
the other thing is, you said the standard question that you have done, Ganesh asked, you do
Yes,
25
sir.
hydroxy and you find 25 hydroxy is normal. What next? What other biochemical test will you do now? Everything looks like rickets.
Okay, sir.
25 hydroxy you have done is normal or high. PTH is high. What biochemical investigation will you proceed to? 125 hydroxy vitamin D.
Vitamin D.
Yeah,
Yes,
so it's
sir.
a very expensive investigation. You should not be doing it routinely because it's got 125 hydroxy, it's got a very short half-life. It doesn't reflect the stored vitamin D levels, so only 25 hydroxy should be done. But if you think of your 125 hydroxy vitamin D, either end organ resistance with alopecia or hydroxylase deficiency, you have to estimate the 125 hydroxy vitamin D. Right?
Vitamin D.
My last question to you.
Yes, sir.
Question. You have everything pointing towards rickets. You have the calcium phosphorus product multiplication is very high. What type of rickets it is? Calcium multiplied by phosphorus, it goes into multiples of, say, 100.
Osteogenesis, sir.
What type of rickets?
Huh?
What type of rickets it is? What is the etiology for rickets? Where the calcium multiplied by phosphorus, the product is high. In other words, you have hyperphosphatemia, you have everything pointing towards rickets. Hyperphosphatemia. Calcium is not high, low. Creatinine is high. Child has a lot of bone pain, giving a lot of clues. And is polyuric. Creatinine
Kidney
is high.
disease, sir.
CKD.
Chronic kidney disease.
CKD. That's the only rickets
CKD.
which the
Yes, sir.
phosphorus levels are high. All other rickets
Yes, sir.
is normal or low. Whereas
Yes.
you get a report of phosphorus being high and you have rickets, is likely to be CKD, chronic kidney disease.
CKD.
Okay.
Yes, sir.
Excellent presentation.
Yes, sir.
You did well in spite of the handicap of your internet trying to pull you down.
Yes.
You did a good job. Of course, Dr. Padmasini and Ganesh were brilliant. Okay, just to encourage students who are attending this program, I thought I should share with them the information that the DNB prize exam, National Board All India prize exam, was instituted by students of late Dr. B.R. Santanakrishnan, former director and superintendent of ICH HC, who was also my mentor and guru. And in his name only this medal was instituted. And it was not a surprise to us when the first time the medal was announced. It was obtained by none other than Dr. Ganesh, the brilliant DNB student those days. And I must also share with you the other information. Dr. Prasanna also got the Dr. B.R. Santanakrishnan DNB medal. No wonder these two people are doing extremely well in their career. Okay.
Yes, sir.
And
Yes, sir.
I'm giving this information to the PGs who are listening to encourage all of them, to stimulate all of them to work hard, read more, and emulate Ganesh and Prasanna. Thank you.
Yes, sir. Thank you, sir. Thank you, sir.
Thank you.
Please stop sharing.
Thank you, Bala sir, for your generous words of appreciation. Thank you, Kokila and Rakshana. Excellent presentation by both of you. And I love the way in which you calmly handled all the questions without getting flustered. Thank you so much, Dr. Ganesh, for being a co-faculty in this program. I thank IAP CCB for this opportunity. Thank you all.
Thank you, madam.
Thank you, ma'am.
Dr. Somasundaram, APCCB and President of IAP and Dr.
So it was
Prasanna.
an wonderful case discussion today at the end of the 11-week series. So still I can see about 48 or about almost a half century PGs were there on this forum at about 9:40. Now when Sir was discussing the final bullet points, which usually he does. And so a very good way to end this session, sir. It is very, very, very my heart is filled with thing that it's all went on fine. All the case scenarios when a few weeks back I was going through some YouTube recordings of the things, so all were practically useful to both the practitioners and the pediatricians. Even today, a lot of the discussions were useful for both the practitioners because short cases, rickets, we all see in our day-to-day practice. And the nutrition case, which we discussed few months ago, was surprised by most of the practitioners, and we had equal number of practitioners on this forum. So I from the whole postgraduates side, and as the president-elect of IAP Tamil Nadu, it's my humble request to SPS sir to continue this trend, which he usually does for being here with us for all the sessions. for the next year, version 2.0, sir, Virtual Gurukulam 2.0, which I will be continuing during my tenure as the president of IAP Tamil Nadu State Chapter. Probably we will select the day which will be conducive for all of us. And once again, my sincere thanks to all the faculty members. In fact, for the today's program went on very well with the two seasoned examiners, not only teachers, examiners who have questioned the postgraduates with the exam-oriented points, and as SPS are told, with the gold medal examiner postgraduates here as examiners. So thank you, Padmasini ma'am and Ganesh, for accepting our request at a short notice. And all the faculties over all the 11 months, very brilliant. All were very appreciated, and lot of knowledge were gained by the PGs who are on the forum. And every day, the number of views in the YouTube is increasing from the old YouTube recordings which we have in the past 11 months. Sincere thanks to Dr. Prasanna. Congratulations to you, Prasanna. I didn't know that you were also a BRS awardee. So thank you for your sincere efforts. Once the program is over, within 5 to 10 days, he calls me, sir. அடுத்தது யார் போடலாம் சார், எந்த காலேஜ் குடிக்கலாம், என்ன இதுன்ட்டு. ஸோ நான் மறந்துட்டாலும் he doesn't forget things. And thank you for your sincere efforts, Prasanna. You will be the part of the team which carries this work to IAP TNSC the next year too. And thank you one and all who has joined on this forum. Over to Prasanna for the completion.
Thank you, sir. Ganesh was thanking everyone. Ganesh, you can.
Thank Dr. Somasundaram and Dr. Prasanna for giving me the opportunity. And as Dr. SBS said, he was our great teacher and we were inspired by him. And the medalists also contributed to him. Thank you.
I also wanted to say the same thing. All the medals is Samarpanam to Dr. SBS, sir.
No.
The teacher of the teachers.
Yeah.
He used to say no, but we used to say it all. He say when somebody is inspiring online, when we work with him, it will be great inspiration. I don't know others how they miss, but I miss working with under sir in Child Trust. Those days are golden days. I'm sure Ganesh will agree with that.
Definitely, Prasanna.
Yeah, I too second that. So, sir, see, even though I have not personally sir would teach student I learn alone. So, the point number 1, point number 2, point number 3, everything goes as the notebook la padikkiradhu mari. It goes into our mind even when we take some lectures in the CME, sir. So, sir, SBS, sir, your final words about how the program went on and for the past 11 months, sir.
It was indeed a great pleasure every month, and people might think that these are all learning exercises only for students. No, they are learning exercises even for senior citizens like me. Every session, you believe it or not, I attend without fail. And in fact, I take down notes. And I learn from intelligent people like Padmasini, Ganesh. So many new things I learned. So, it's fantastic. Thank you, Dr. Somasundaram, for giving me the opportunity. In fact, the only thing I'm angry with you is you're giving credit to me. I didn't do anything. Everything has been done by Dr. Prasanna, and I'm unfortunately getting the credit. Actually, the credit should go to Prasanna. I didn't do anything. Everything was decided and planned meticulously and by Prasanna. Please give him a big hand. To Prasanna and not to me. I didn't do anything except sit through all the 11 sessions without fail. That's all I did. And I learned. Thank you very much.
Thank you, sir. Thank you. We'll carry this with this charisma of what is happening here to next year, sir, with your support. Thank you.
Thank you, sir.
Thank you. We'll end the session, Prasanna.
Yes, sir.
Yeah.
With this, we'll end the session, and all these recordings will be available on YouTube. And I was one day astonished. One of the teachers who is going for an exam, PG exam, said, I watched some of the videos and I took some questions from the videos so that I can ask tomorrow. So, as sir said, it is not only for the PGs, it is also for the teachers. So we'll share, we'll compile and share it across groups so that everybody will be benefited. Thank you. Thank you. One final thank you for everyone.
Please put that link in our official group also, Samsundara. The link put.
Sure, sir.
Yeah. See, after the 7 sessions, we did that. Now, after 11 sessions, probably next week, we'll be able to compile and then put it across.
Thank you. Thank you.
Thank you.
Thank you. Thank you all. Good night.